everybody. This is Carol from STS. Thank you for joining. I hope you enjoyed the spring version of Vivaldi's Seasons. I don't know if it's a quartet, but it's a seasons thing. So anyway, welcome to the webinar. This is the Adult Cardiac Surgery Database monthly webinar for April 7th. We're going to get started here. First, I'd like to welcome the folks that have joined me today. We have the STS team, Leanne, Sydney, Emily, Melinda, and Catherine. Thank you all very much for joining. The IQVIA team, Jean, Joe, Melanie, Michelle, and Rhonda. And with special presenter today, Patty Toyer from the Michigan Society of Thoracic Surgeons, where she is the project manager, and she works directly with Dr. Prager as his project director. For those of you who know Dr. Prager, he is the past STS president. We will be giving an IQVIA update. Patty is going to talk to us today about AQO abstractions to give you all a little bit more information about what that all entails. Maybe it's intimidating to folks, just to maybe ease your mind about things that you are doing at your site and presenting that information and how best to do that. And then we're going to be talking about NQF measures today. This is the first, this will be the first of maybe 2 or 3 webinars where we'll be talking about NQF measures, star ratings, and ultimately ending up answering the main question is, why am I getting 100% on things but not getting 3 stars, which is what a lot of folks ask about. So we're going to first start with NQF measures and kind of go through those, and then we'll have time for Q&A. First, I'd like to talk about some important dates. We have the monthly webinar today, and then we have a TVT webinar tomorrow at 2 p.m. Central. The information is on the STS webinar page, and there was email sent out as well. If you'd like, maybe Leanne can put the link to the webinar page into the chat box so you can find more on that. We have a user group call on April 21st. May 5th is our next monthly webinar. We'll be talking more about the star ratings and things along that line. And then we have a user group call on May 19th. May 28th is the Harvest 2 close date, and that will contain data through March 31st. And then June 2nd is the opt-out date for Harvest 2. And then I just got an email from the STS regarding the COVID data. They just released this. It was presented by Dr. Gwynn at the STS annual meeting. It's the first look at COVID data in the database. Here's the QR code. If you just hold your phone's camera up to that, you'll be able to, it'll take you right to the site where that's listed. Otherwise, it was sent in the email from STS. This is our weekly newsletter that goes out. So it was really interesting to see that, and how the data in the database is being used. It looked at regions that were most affected and timeframes and how case counts were affected. Just preliminary look at the data as we're getting it in. So if you're interested in that, there it is. And now I'm going to hand it over to Joe Brower with the IQVIA update. Joe?
Thank you so much. Good afternoon, everybody. Starting out with an update in regard to the MIPS 2020 submission. The CMS reporting period was officially closed on March 31st. So all approved submissions have successfully been sent over to CMS at this time. Per the Quality Payment Program website, the final feedback will be available for you in summer of this year. If you want more information about the MIPS program, you can go to the Quality Payment Program website, and the web address is there, qpp.cms.gov. All right, some updates is for the database, starting with the risk-adjusted dashboard report. There was an enhancement made, STS 6008. A footer has been added for the regional report that displays the participant-assigned region name, the total number of participants in your region, and the total number of cases for the region per procedure. So that should be visible. This is something that was added in an update on March 26th. So it's been in there a couple of weeks now, but this should be visible to you when you run those region reports on the risk adjusted dashboard. All right, next slide. defect that we resolved. This was also March 26th, also on the risk adjusted dashboard, STS 6188. The dashboard report will display cases. The dashboard report was displaying cases that did not have anti-lipid medications prescribed in the patient drill down. And so that has now been resolved. All right, and then a couple defects that were fixed for the participant dashboard report. This is your non-analyzed dashboard. STS 5761 and STS 5831. The participant dashboard was showing the ECMO and temporary assist device variables as missing, even when the variables were not being collected based on the parent fields. And so that has been resolved now. So there shouldn't be a bunch, like hundreds of missing cases showing up for those variables. And I think that was it for me. Just the usual notes that if you have submitted a ticket, please rest assured that we are looking into it. And we will be reviewing additional items to bring up for the next user group call.
Really great. Thank you, Joe.
Thank you.
Okay, and now we are going to hand it over to Ms. Patty Toyer from the Michigan Society of Thoracic Surgeons to talk to us about abstracts. Do not fear, abstract season is here. And Patty's sharing her screen and we see it.
Okay, great, thank you. Thanks for having me talk, Carol. People that know me know that posters are my favorite part of AQO, and it's for several reasons. First of all, I think my attention span is very limited. So I love to run through the poster session, look at the pretty colors and graphs, read the introduction and conclusion, and then decide if I want to spend my time reading the entire poster. And the second thing is I always find something on these posters that I can take back that is useful to my practice, always, always. And I meet the greatest people, and I always appreciate the effort and the time they've taken to share their stories. And the AQO committee has made it really simple to learn how to create an abstract, and it's really geared for every single one of us to try our hand at abstract writing. So I'm just going to go along and explain the basics of writing an abstract, and I've included pearls of wisdom from the real experts, Morley Herbert and Sima Prince from Dallas, Texas. So thank you, Morley and Sima. Simply put, an abstract is a short story that helps you connect to the audience, since many of us have the same interests, challenges, and issues at our centers. You will show that you've identified a project, a problem, or research question, what you did to correct the problem or conduct a study, and what happened as a result, or what did you discover. The topics for the STS abstracts must use STS national data fields or your custom fields to show the results of the scientific research, your quality improvement project, your data abstraction process improvement project, whatever you choose. And your imagination is the only limit. And you're in the best position to know what your data shows and all the hard work that your site has done. And this is applicable to adult cardiac, general thoracic, and congenital. You'll be asked to identify what type of abstract you're submitting, either it's scientific or quality improvement. I always struggled with these because the lines are kind of blurred to me. While it seems they're blurred, but scientific abstracts really are research projects where you are testing a hypothesis to create new knowledge, where quality improvement abstracts typically are related to a hospital activity demonstrating change in behavior or outcomes. You have to remember that these abstracts must be original work, not something that was presented by your site, your hospital representative at a previous national meeting. This is just a sample abstract that was submitted in 2018 that I like, that shows the different sections of the abstract: the title, the background, methods, result, and conclusion. And you can see they included a nice graph to visually display the results. So I'm going to go through each section. The title is one of the most important parts of the abstract. It's the first impression. Therefore, you want it to be great. You want it to be accurate. You don't want to mislead them. And it has to be consistent with your project. It kind of identifies what the project is about. It should be compelling because you want the committee and eventually the audience who's looking at posters, you want them to read the poster, and it should orient them pretty quickly. Some of the examples I provided here show you know exactly what this poster is about. a multidisciplinary approach to decreasing intraoperative blood product usage in coronary artery bypass surgery. This was from St. Elizabeth's Health Center in Youngstown, Ohio. This is an older poster, but it was one of those early posters that showed a multidisciplinary approach to intraoperative blood decreasing. It really showed us early on that one single intervention is unlikely to stand out when you're doing so many things with so many team members, and that's okay. And their results were phenomenal at a time when everybody was looking at blood transfusions. Improving data collection through a strategic data management plan from our colleagues at the Children's Hospital of Philadelphia. This is our congenital colleagues. By implementing a new data collection process, they implemented new training procedures, monthly reconciliation, and they were able to decrease their missing data significantly. It was very impressive. And I think that is even though it's congenital and we're not all congenital, there's something in that poster for each and every one of us. Prevention of postoperative atrial fibrillation and cardiac surgery from Green Bay, Wisconsin. They shared their AFib prophylaxis protocol in the poster. They showed results that decreased their post-op AFib from 30% to 12%. I mean, who doesn't want those numbers? That was amazing. The last example is the impact of a dedicated thoracic unit on postoperative pneumonia rates following lobectomy for lung cancer from Northside Hospital Cancer Institute. This was obviously from the General Thoracic Surgery database, and they focused on pneumonia, and that is obviously an outcome followed by every single thoracic surgery program. And this poster actually became an amazing resource for people. So these are just some examples of important titles. The background is where you explain the problem or your research question. Explain why it is important and why it matters to others. The background should be strong. You're competing for people's attention because everyone's busy. So you want to keep it simple, a brief 1 to 2 sentence summary of the study's purpose and current state of research in the field. It can include what is known, believed to be known, or the question to be answered. You only want to put relevant information here. A common mistake in abstract writing is you start to explain how you conducted your project, and this is not the place in the background. The place for that is in the methods, where you will explain how you conducted your study or implemented your project. You want to state what patients were included, excluded, how the analysis of the data was carried out, clearly and briefly explain how you did what you did. And this is not the place to explain why. That was in your background. And this one right here is the most common reason an author is requested to revise their work. The abstract results are the meat of the abstract. The data shows what happened as a result of your analysis or your intervention. This is a summary of your findings and must include data. Tables and graphs are an excellent tool, but they are limited. You can only have one or the other. And there's actual limits to the number of columns and rows your tables can have. But in the poster, you can put as many pretty figures and graphs as you want. And these tables and graphs really help with the word count because they're not included in the word count for your abstract. This is a big reminder when percentages are used, the absolute numbers should be presented. And a little tip is don't repeat all your data in the results that you're putting in your table because the table is a time word space saver. And the tables and figures actually should speak for themselves. Statistical support is helpful. You want to know that the changes that you made were actually statistically meaningful. There's simple downloadable stats programs that can be helpful. You can phone a friend, you can partner with colleagues that have maybe a master's degree or a DMP, residents, nurse practitioners, PAs sometimes are familiar with statistics. And also to remind you that regional comparisons are not allowed. The abstract conclusion is a concise wrap up of what ties in the background or problem statement and the results. There's no need to repeat the same words over and over in the results, but state why the audience can benefit from this knowledge. There's another tip here that this is where you want to make sure the reader knows what you want them to know. Make it short and sweet and drive home your point. you want to leave the review committee and eventually the audience, they really want to read your poster by reading this conclusion. Some people actually will walk up to or look at an abstract and read the title and the conclusion. So if you haven't attached, if you grab their attention at that point, you probably lost them. So to wrap up, you have to be aware of the abstract submission guidelines and follow them. There is a word limit of 250 words, and that's difficult. It's really, really difficult. And that's why I repeated, keep it concise, keep it brief, and remember to consider your audience. Local terms on the East Coast might not be understood on the West Coast. And watch your acronyms and abbreviations for the same reason. We always suggest having someone give it a proofread, or second pair of eyes, because you know what you're saying, and it might not be all that clear. The other caution is to remember you're representing your hospital. You want to make sure that you have approval to publish these data, because that's really what you're doing, is putting data out there in a published manner. The guidelines look like this. And if you read these and you follow these are a fantastic guide for success for abstract writing. This is just the process of submitting your abstract. You will get an online notification. It's so easy now just to upload the different sections of the abstract. It's really easy peasy. The review committee gets back to you, and either you can get your abstract accepted, rejected, or request for revision. Typically, revisions are because you didn't follow a guideline. And if you can follow the guidelines, change it up a little bit, resubmit it, then you'll be asked to create a poster. And now the meeting's virtually, it's even easier because it's just a PowerPoint slide. So in conclusion, we all know that the last year has been really challenging for each and every one of us. Quality and research has definitely looked different and continues to look different at our site. Although I know that there's many, many good things that have occurred and continue to occur. So please don't be intimidated, because it really is easier than it looks. There's multiple examples available. And it's great to share your success. We had the privilege of listening to Jerry O'Connor. He was a 20-year director of the Northern New England Study Group. And he actually told us the best part of collaborative work is sharing graciously and stealing shamelessly. I think posters make it really, really easy to share our great results. Oops. And here's just some posters from last year, and as my exit, Carol.
Patty, this was a really great, clear, concise presentation. Thank you very much. It means a lot that you were able to present and did a great job with this. I really urge everybody, don't be intimidated by this. I know that every site is doing something with their data and making improvements. And now it's time to showcase what your site is doing. Don't feel like you have to be an academic center. Everybody, even, at the very local hospitals, are doing amazing things internally, and sharing that information with everybody improves the care of all patients, not just at your hospital, but every patient that's being cared for with cardiothoracic surgery can benefit from what you're doing at your hospital. So I just urge you, when we do open the submissions up, that information will be coming, and we'll be sharing more information about it. But please take the opportunity to talk internally at your facility, see if you have a project that you have results on that you're seeing. It doesn't have to be good results either, right? It can be something that maybe you tried, you thought it was going to work, and maybe it didn't turn out the way that you thought it was going to, but in the process, there's always something learned. So it's always that take it back, review it, and make changes going forward, and how the process of quality improvement evolves is really what is the most interesting to folks. So just, I urge you to take the leap and see if you can find something to submit on. We'd love to review it, have our abstract team review it, and share it with folks throughout the meeting. And this is going to be one of the bigger AQL meetings, so I'm really looking forward to that. Thank you, Patty, and I've enjoyed working with you, so I appreciate you taking time to present on this.
Oh, thank you.
Yeah, I'm going to share my screen now. Let's see here if I can do it without screwing up. Can you see it okay, folks? Okay. Can you see it okay? Anybody?
Yeah, it looks good.
Okay, thank you. So thank you, Patty. And now we're going to talk about NQF measures. This is a dense webinar. There's a lot of information, so it will be posted in a couple of days. You'll probably want to go back and review this, both for the abstract part and then what we're about to talk here. We're going to talk about the NQF measures, where stars come from. So first, I'm going to, if I can find my right screen to pull over. Okay. This is the STS website. Under quality and safety, we have our performance measures. And you'll see here, when you click on this, it's going to open up to the NQF measures. The NQF measures, we have some that have been derived from, that originated from STS, and they have NQF approval to be used, meaning that we submitted to NQF the idea of this quality improvement tracking. Either it's an outcomes process or an outcomes measure or a process measure. Outcomes measure are things like mortality or stroke. Process measures are, did you do the right thing in the process of getting the patient to surgery safely? And we use our database to develop these measures by showing significant relationships between what is done, what the patient's coming in with, so risk adjusted, and what happens during the process of going to surgery, which is the process measures, and then the outcomes. And we look at the data across a significant time frame and determine if there's if it's relevant to the outcomes or process of the patient. And then NQF reviews our data and they say yay or nay. So we have been able to get, I think, over 15 or 16 NQF measures endorsed using the data. These NQF measures are what we use for star ratings. So this is kind of where the star ratings are born. And this is our first step, is looking at these NQF measures and seeing how you're doing at your hospital related to what is included in the measure and how your site is doing. So outcomes, we could look at things like renal failure or surgical reexploration. And this is risk adjusted data that we take in, all those risk factors. And we'll talk about this in the next webinar, but where we look at risk factors and we can kind of level the playing field for renal failure. Say we're looking at renal failure specifically, and we're looking at your preoperative creatinine or things like that, and we can adjust your outcomes of postoperative renal failure by mitigating it against the risk of the patient when they went into the operating room. So that's the risk adjustment part of it. And we'll talk about risk adjustment in a follow-up webinar, but just to give you a little bit of heads up of what these NQF measures look like. So we have multiple NQF measures, and you'll see things that are familiar, like this Cabbage composite score. This Cabbage composite score, it has its own NQF number, but it's made up of all of these different NQF measures. And we look at the perioperative medication domain, we look at the operative care process domain, we look at the operative mortality, and we look at the risk adjusted morbidity. So each of these are developed separately, and then they're combined into this composite score. And this is what your star rating is based off of, this coronary artery bypass graft composite score. They take the data at DCRI, and we'll talk more in a follow-up webinar about how they are calculating the star ratings. But for right now, I just want to give you the basics about the NQF measures and what they look like and how to tell if your patient should be included or excluded in that measure. So I wanted to do this before I post another document online, just to give you a heads up of how to read it and what it all means. So we'll get to that document in just one second. So these are the performance measures, measure descriptions, and there's multiple here for review. We're going to post this document here. Let me pull it over. This is and I don't know if anybody, if you have seen this or if you reviewed this, it used to be posted in your paper PDF or the PDF reports regarding the NQF endorsed measures. It's been updated for version 4.2. So we'll start at the beginning. We have the title, which is the first one is the risk adjusted renal failure. It's NQF 0114. And this description is really the population. Same thing with the numerator. So it's going to look at percent of patients under 18 years of, aged 18 years and older undergoing isolated CABG. So we might get a question about, well, does renal failure impact those patients who are undergoing AVRs? And the answer to that is no. This is just a CABG measure. And then without pre-existing renal failure, who develop post-operative renal failure or require dialysis. And then we get into the numerator and we can see we're looking specifically at isolated CABGs who develop post-operative renal failure or require dialysis. And we get more into the definitions about it, and we'll get into the exclusion criteria as well. So the denominator is all patients undergoing isolated CABGs. The numerator is those patients indicate whether the patient had acute renal failure or worsening renal failure resulting in one or both of the following. And we know that it's an increased serum creatinine level of 3.0 or 3.0 greater than the baseline, or serum creatinine greater than or equal to 4 milligrams per deciliter. Acute rise must be at least 0.5 milligrams per deciliter. And then a new requirement for dialysis post-operatively. Then we're going to look at the exclusions, because this is what's going to exclude the patient from this measure, which means they will not impact your results at all. They're excluded from the denominator and the numerator. They're excluded from the denominator, so they're not included in the numerator. Those patients would be patients with a documented history of renal failure, a baseline serum creatinine of greater or equal to 4. Prior renal transplants are not considered preoperative renal failure unless the transplantation has their creatinine of being greater or equal to 4. How do we identify these patients? Is by dialysis being marked yes, or the last creatinine greater than or equal to 4. In version 4.2, we also added in the patients that expired in OR as an exclusion criteria. So those patients are also removed from the numerator, from the denominator, and they would not impact your, they would not be counted towards your outcomes for that measure. So hold on one second. For some reason it made it bigger on me, and I didn't mean to do that. So this document will be posted online under the resource document for version 4.20 under additional resources. It'll be called the NQF endorsed measures, and you'll be able to see each NQF measure that's listed here, the populations that are included, how we determine what the denominator is the 4th column, what the numerator is, which is the 3rd column, and then the exclusion criteria. So we'll look again at surgical reexploration. These are those patients that have to go back to the OR. We get a lot of questions about this, well, does this patient, where did it go? Oh no, hold on. Oh, I know what I did. Sorry about that, everybody. Okay, so I do know how to work a computer, I promise. So we get a lot of questions for this group about our non-cardiac procedures included, or our other cardiac reasons for reoperation included. Both are legitimate questions, and this is where you'll find those answers to those questions. So this risk-adjusted surgical reexploration, we're looking at patients aged 18 or older undergoing isolated CABG. So again, this is just for CABG, who require the return to the OR for bleeding with or without tamponade, unplanned coronary artery intervention, valve dysfunction, aortic reintervention, or other cardiac reason. And then that's who we're looking at. We see that it's listed out here. It's mapped per version, what these mean. So for version 2.8, it was different than what we did in 2.9 and 4.02. The reason it was different is because we changed this where it says graft OR reintervention for graft occlusion. For those of you who have been around long enough, you know that in 2.9 we got rid of this field and we added in a field or an option called re-intervention for myocardial infarction. So it replaced the re-intervention for graft occlusion, but it's still mapping the same data point, which is that patient had to return to the OR because they either had a myocardial infarction or they had something that required a stent, maybe a cardiac stent placement, something like that. It was either in the native or in a graft. And it could also be for surgery, not just PCI. So they also could have undergone a CABG versus a PCI. So we're collecting it a little bit differently in 4.20, but it's still being mapped to this risk adjusted for surgical reexploration. And we look at things, re-op for bleeding is marked yes, re-op for valve dysfunction, either surgical or transcatheter, re-intervention for myocardial infarction, and aortic re-interventions, and re-op for other cardiac reasons. What's not included in here is that return to OR for non-cardiac reasons. So if your patient goes back to the OR and it's not related to any of these events, it would not be included in this, in the denominator for this risk adjusted related to surgical reexploration. Again, this is all patients undergoing CABG. The STS procedure algorithm, which is our PROC ID chart. We talked about that, I believe, April 1st in the webinar on April 1st of 2020. And then version 4.20, cases are removed from the denominator if the patient expired in the OR. And it goes on that one is a good one because I can show you that there was a change between versions and how we address that. It goes on to further ones. We talk about antiplatelet medication. And I also think, again, this is very dense reading, but once you read it, you can understand what is actually being looked at for these and what patients are being excluded from these measures. So you can see this patient, this is the antiplatelet medication post-discharge. And for this one, we do get questions about this other discharge antiplatelet medication. Is that included or not included? And for for all three of the versions that are listed here, 2.81, 2.9, and 4.202, other discharge antiplatelets do meet the requirements for this measure. So we have discharge aspirin, discharged ADP inhibitors, and then these other antiplatelet medications will all get you the credit for meeting this antiplatelet medication at discharge measure. Patients that are excluded from this measure are in the last column, any in-hospital mortality, or if there was a contraindication on the discharged aspirin, ADP, or discharged antiplatelet. If the patient was contraindicated for those medications, the patient would be excluded and would not count against you if they did not receive it. For version 4.2, we added in here that in hospital mortality, the contraindications, or the patient was discharged to hospice, because remember, we're looking at those hospice patients now as mortalities, and if patients left AMA. So those changes that we made on the data collection form actually help you here, because you're not getting, if you will, dinged for not giving the antiplatelet medication as a discharge medicine for patients who are discharged to hospice or who left your hospital AMA. The other things are expired in OR, the discharge mortality status, indicate that the patient was discharged in hospital. I'm sorry, died in hospital, left AMA or hospice. So I think that those three, the first three are probably really good examples of the rest of the form. This will be provided online under the STS version 4.20 resources. I just wanted to give you a run through of it first to give you an idea of how to tell what's going into your populations. This is used in conjunction with that procedure identification chart, which we talked about on that April 1st, 2020 webinar. That kind of identifies what objectively goes into those procedures. If you're looking at, isolated CABG and the patient has an intracardiac lesion for AFib, that patient is removed from the isolated CABG population. But if it was an epicardial lesion for AFib, they're kept in. So that's kind of what that PROC ID chart shows you at a high level. more than just AFib patients, but that was an example. And this shows you what goes into those measures that we're using once those isolated CABG patients or AVR patients or mitral valve patients are identified using that PROC ID chart. So the first thing you would do is you would look at that. Let me see if I can find it here quickly for you. And we won't go through the whole PROC ID chart. We did that already, but when you go to the STS registry and you pull up the adult cardiac and you go to this under additional resources, you have your procedure identification chart. This is how you identify what makes up these procedures. So isolated CAB, AVR, MVR, AVR CAB, and then there's more down, about halfway down on page 6 or 7 with additional procedure types. So once you identify what this patient is, if this patient is an isolated CABG, then you can identify which process measures they're going to be, that's going to be applied to that patient. Once you do that, you can see then what else is keeping that patient in the denominator that they may count for or against you, if any of these things were to happen to that patient. So it's kind of a high level overview. This is where, again, where stars are born. We look at these NQF measures to determine how your site is doing versus all of the other sites in the cohort, and that's how the stars are determined. We'll talk about more about that next time. I know that this is really dense. Happy to take questions on it. Again, I will PDF this form and we will post it here under additional resources so you have access to that. All right, so I'm going to stop there because I think that's quite a bit of material and I'm sure it's a lot to take in. And we're going to go over to questions if you all are ready for questions. Okay, and then the IQVIA support plan, resources, and my contact information and STS database for operational questions. And then questions. So let's go and see what we have. Oh, Joe, this one's for you. Joe and Melanie, is there an update to the risk score match?
This is Melanie. I can answer that. There wasn't a recent update to the risk score match. So if there is a specific question, if you could post it, then maybe we can see if we can answer, or if it's a ticket that you need to log with support, but just provide a little bit more context and we can see if we can help you.
Great, thank you. Thanks, Melanie. Next question is, I'm not getting the weekly newsletter. So I misspoke. That what was sent out was our spring, was a quarterly newsletter that was sent out from STS. And I think you can sign up, oops, wrong thing. I think you can sign up here, or you can go to, let's see. So that's our database news. This is the STS news that comes out 4 times a year. And then the advocacy monthly comes out monthly. I think on this one, you can access the old issues.
Yep.
And I'm not sure how you sign up for it or if it just gets sent out. Oh, maybe you can reach out to stsnews@sts.org and ask if they would be able to add you to their distribution list. Otherwise, you can access them online under publications and STS news. Okay, is submission date May 28th or May 19th? So the slide said May 28th. Hold on, I'll get there. There we go. Harvest 2 closes on May 28th, and it contains OR dates through March 31st, 2021. Is there a specific section on the STS site where previous abstracts are posted? It would be nice to have access to some of these, and maybe the access is there and I just don't know where it is to locate it. So Emily, are you available to take that question?
Yeah, we don't post the abstracts, but we do post the, we've posted the posters, the actual posters that were presented on our website. For 2020, though, they are on that virtual platform, which is still open. And if you signed up to attend the AQO meeting last year, you still have access to that, and you can go in there and view the posters. As for 2019 or 2018, if you go to past courses, you can click on that, and then it'll take you to like 2019's meeting or 2018's meeting. So it looks like you have to log in for that one, but if you go to the 2018 one, Carol, you can see the posters there.
Okay.
So past courses, 2018. And then if you scroll down and click on poster presentations. And I just wanted to also comment that abstract submission will be opening soon. We don't have a final date yet for when it'll open and when it'll close, but we are aiming for the close date to be around mid-June. So I would say if you have a quality improvement project or a scientific abstract you would like to submit, you know, kind of start working on that now. STS will send you an email to the abstract submission site. We'll also put it on our website at that live courses link, and then there's a 2021 AQO webpage. So if you need any specific information about AQO, I'm Emily Conrad, and I'll put my contact information in the chat. Thanks.
Thank you so much, Emily. So just to recap, to find those posters, if you are interested in doing or kind of curious about what those posters look like, on the STS website, sts.org, if you go to meetings and then past courses and scroll down a little bit, you go to the 2018 Advances in Quality and Outcomes, and you'll be able to see, these are the agendas that we had. Down here, poster presentations is where you'll find those posters for examples. And then when we do have more information for AQO 2021 under live courses, it will be here. And this is where you'll find information regarding the abstracts and when we have registration open and things like that. So that's that. Good question, Heidi. Thank you, Emily. Can someone tell me where to find these documents that will help with abstract writing? For example, where presenters got the abstract instructions for AQO 2020. So that will be under the live courses and then 2021 AQO. It's not posted yet, but it is coming. And I think Emily, do we email folks out when we do post it, did you say?
We will. Yep.
Okay.
We'll include those guidelines, and we'll include the submission link to the website.
Okay, great. Thank you. Where could you find the NQF measure chart with definitions shown that include info from version 4.2? So that will be posted under registries, STS National Database, Adult Cardiac, Data Collection Resources, and then it will be posted here underneath. Oopsie, my mouse stopped working. It'll be posted here underneath the resources, additional resources, and I'll send it over to our marketing team to ask them to post it by the end of the week. Okay, and then thank you for posting the NQF numerator, denominator, and exclusion criteria. We have been piecemealing this together into our own document since moving to 4.2. Yeah, I kind of figured, Melinda and I had talked about it, and I kind of got that sense from some of the emails I was getting. So I do hope it will be helpful to sites. It takes a while to do the mapping. So as you can see, every little thing has to be remapped when we do a version change. And that's part of the reason why when we switch versions, Harvest 1 takes a little bit longer to get the data over to DCRI, for DCRI to do the analysis, and for IQVIA to populate that data. All of those steps need to get remapped. So DCRI has to do remapping, IQVIA has to do remapping on both the uploader side and on the benchmarked risk adjusted report side. So there's a lot of different pieces behind the scene that happens. It just takes a little bit longer to get through all of that to make sure we do it correct. So yeah, happy to share that, and I'm glad it's going to be helpful. What does scored any or none concept refer to risk adjusted morbidity in the performance measure? Thank you. So that's a great question. Any or none means that if you have one morbidity, it counts the same as if you were to have 5 morbidities. So there's no weighting on the morbidity for this risk, for these risk models. It's you either have one, which counts as the same as many, or you have none. So that's what any or none means. And then where will this, so it's just if you do one, if the patient ends up having a stroke, it's going to count the same against you as if the patient were to have a stroke and renal failure, or a stroke and something else. Now, the worst outcome, of course, is death. And we'll get into that further because on the next webinar, I'm going to show how those different measures, how the different outcomes and process measures weigh, how their weight is used in the calculating of the scores of the outcomes, because there's different weight. For example, the internal mammary doesn't have as much weight as maybe the patient having a stroke when the scores are all put together and the star ratings are calculated. But we'll talk about that in the next monthly webinar, which will be May, because it gets very detailed. And I want to go through to show you all how to read the national report overview and what's in there, because I think it'll be very interesting and helpful for you if you need to explain it to somebody at your site. So it will be posted. I'll post this document later this week on the additional resources. Question about DC meds. If patient has contraindication only to aspirin, does that mean that they are excluded, or does there also have to be a contraindication to antiplatelet medication? And I think that you have to have, so this is a good one. This is the answer is or. So if they have discharge aspirin or discharge ADP or discharge antiplatelet was contraindicated. So it can be any of these. It's not an and, so you don't have to meet the criteria for all 3 of these. It could be any of these as being a contraindication. And this is another question we're going to cover regarding the 100% and not 3 stars. We're going to talk about that more because there's more to the story than a very simple answer about how that happens regarding sites that get 100% but don't get 3 stars. So we'll talk about that in May. Same bat channel, same bat time. Period ending 9:30. I'm not sure your question. Oh, when will it be? Okay. Period ending 9/30/2020, which is Harvest 4. When will it be released, as well as period ending 12/31/2020? The Harvest 1 data is back at, the Harvest 4 data is back at IQVIA. We anticipate STS to review that data in the UAP, in the user acceptance testing platform this week, and hopefully we'll have it. IQVIA is doing a calculation adjustment that will be in place hopefully mid next week, and then we'll open it up to other UAP users, beta testers, hopefully by the end of next week. Melanie, do you agree? I don't want to misspeak and make a promise on IQVIA's side, not knowing.
That's the target. Yep,
Yeah,
that's the target at the moment. That's the target.
Okay, so then, so hopefully within the next few weeks, we'll have Harvest 4 data up, and then Harvest 1 will follow closely behind. DCRI used to send a detailed report quarterly by procedure type. That was a good resource for benchmarking our results. What replaced that report since IQVIA took over? So that's located on the IQVIA platform. See if I can pull it up here for you very quickly. Hold on 1 second, sorry. That's now on the IQVIA risk adjusted benchmark platform, and that will contain all your quarterly reports as they're coming over from IQVIA. And let me know, Bob, if you have further questions on that. I can try to share my screen, but we've done quite a few webinars on that and where to find your reports.
Girl, I can pull that up for you to help out and share if you have it. Do you have it? Okay, because I'm logged in. I'm logged in
thank
and
you.
I have,
Okay.
yeah, I have the window open. So, and it's the 999.
Okay.
You want me to just show mine?
Oh, I got it. I
You
think
got it? Okay. All
Yeah.
right.
So this is the IQVIA platform. When you log in, you go to operational reports on the left-hand side here. The report that you're looking for, which is the quarterly report, is this ACSD risk adjusted dashboard report. This is going to contain your risk adjusted and your benchmarked outcomes. When you select that, you select a time period. Right now we have, this is Harvest 1, 2020, Harvest 3, 2020. Harvest 3 is through through June 30th. So that's the most recent one we have available. Harvest 4 is coming soon, within the next few weeks is the target date. This is just going to take a little bit of time to load. But as it loads, you'll be able to see your star ratings, your benchmarked outcomes, which will show you benchmarked against your like groups and the STS national averages, and then your NQF measures as well. So as that's coming up, let's see. So this is what the report looks like. It's very similar to the PDF report, except it's in electronic format. And a little bit more fancier because we have the drill down capability. So quality ratings are your star ratings with details, your rating trends. This will populate over time, showing you star ratings changes over time. Your NQF reporting, which is your process and outcomes measures that we just reviewed. Your risk adjusted and regional outcomes. These are where you'll see your, I'll show you. This is where you'll see your mortality. These are your NQF measures. These are the things that go into your composites, and then length of stay, procedure length of stay, and total length of stay. Your site data versus the like group, the region, and STS. So things that were broken up previously, what you would have is you would have your site data, you would have your like group and your STS. The region was posted in a different part of that report towards the end of the PDF. It's now here, all contained within one section. So this shows you how you're doing. And then if you go hit this little home button, these are your benchmarked reports. You can click on the different option, which is similar to the sections within the data collection form. And then this is a 999, which is the national report. So I don't have site data, but I do have the STS numbers, what I would look at, because this is the overall national report. So these are, would be your risk factors, demographics, and things like that, where you can find in different graphs. So that's that. Okay. I think the sign up for the STS newsletters are after you log in and somewhere under the your profile information. I think you're right, Annie. I think that's where it's at. I think you have to set up an account with STS to do that. Next question is there documentation on how umbrella reporting is calculated? If you have a specific question, I'm happy to ask Melanie if she's able to answer that. But essentially, it's whoever has signed the agreement to be in the umbrella report. It's aggregated data.
It's aggregated data, exactly.
Okay. So STS used to publish quarterly the tables with ODE multipliers and event percent that could be used to calculate the risk adjusted. So yes, we do still publish this, Heidi. It's under the, where'd it go? Under the library. I'm like, library. I know it's there. The library. And then
I believe it is called.
Is it this one? That's the composite summary. Hold on.
It's the STS ACSD 2020 Harvest 1 multiplier tables, or the Harvest 3 multiplier. Yeah.
So they're published here. The Harvest 1, the multiplier tables are published here. It just takes, once we upload the data, it takes a couple days to get that back from DCRI, and then we'll publish it. So it might not be available right away, but we'll get it up there. And it'll download into a PDF. Is there published national averages that STS IQVIA can publish for vendors to use? It's helpful to have these for our scorecards. I'm not sure what that is, Heidi, but I'm not sure what you mean by published for vendors to use. So we don't publish we don't publish an executive summary any longer. But you have it in your national reports that you get back. You have the STS national averages in your reports. Should we now use these definitions versus the endpoint definitions when calculating outcomes? So the endpoint definitions, I think, are a little bit different, but they're might be essentially this. They should be matching. I'd like to see what that document is that you're talking about. So this is the risk model endpoint chart, and these are not the NQF measures. These are just showing you what's going into the overall counts. When we get into the exclusion criteria is where it's a little bit different between these and what's going into the NQF measures. And I don't know, Melanie, do we need to, this is still accurate, I think. This is from February of this year.
Yes, that's the latest. I believe that's what's been posted, came from
Yeah.
DCRI, the latest on the website.
Yep.
Mhm.
Okay. I agree. Is there any place to post the how to calculate risk-adjusted outcomes like we had in the Duke report, along with all the explanations that came with the Duke report, such as what % of nation received 3-star ratings? So that what % of nation received 3-star ratings, that's all on the IQVIA platform under the, this is the Harvest 3 composite quality summary rating. And this will show you this will show you that information. This is all we're posting regarding that. And then how to calculate risk-adjusted outcomes like we did in the Duke report. I think, I thought that we had that in the national report overview.
It is. I think there's a section that walks through how to calculate with scenarios.
Yeah, and we're actually going to go through this on the next call. So that will be our call for May. We're going to go through the national report overview, talk about the risk adjusted a little bit further, and get to those why do I have 100% but not 3-star questions. Does STS allow us to map structured data fields within the medical record to our third-party vendor? We only have a limited number at this time that can be automatically abstracted, and those you'll find in the software specifications, which is posted online under additional resources. Oops. I second that question from Sue about how, so right, that's in the national report overview, and we'll talk about that more next time. Pat, does any or none also apply for discharge medications? So we, the discharge medications we have are, it's not a composite measure for discharge medication. So we're not looking at more than one. We're not looking at like antiplatelets and discharge beta blockers in one measure, other than the composite measure. We're looking at that question was related to the mortality morbidity outcome. Or, okay. Will an email be sent out to users when the Q4 reports are released? I think we plan to do that. Or we'll put it in notifications, Melanie?
I think Jane had said that there was an email notification, and we would also post in the notification within the platform.
Thank you. Will IQVIA include the count of cases in the risk adjusted tables?
I thought counts of cases were available within.
I thought so too. Let's see.
Yeah, if we were to go to, I guess it depends on which section we were looking at also.
I don't know if I'll have that in the 999 report.
Oh, that's true. Well, the line would be there, the entry that I'm thinking of.
It's total case count, right?
Total
Yes,
case count.
on the demographics table, I think.
Correct. If you're in the benchmark sections.
Yeah, under the demographics.
Under demographics, that's going to give you your total case count.
Yeah, so let's see if it will pull it up for me. For some reason, it just took me back to the screen, different screen, but let's see if that works. I'll show you where that's at, Julia. Can you explain again what or who is in the region on the risk reports. Is the region your state or several states? So I see Melinda's answering that one. There is an explanation in the national report overview that's posted online about how the regions are calculated. I'll let Melinda answer that. Just see she's typing her answer. Does the national data have the COVID cases still in, or are they removed prior to the STS data on the benchmark report? Melanie, I'll let you take that one. I'll let you take that one.
So the next, I believe, we're going to have to verify with DCRI when they're pulling those from analysis. I believe that was for the H1 2021.
That's right. They pull them from it. Well, we pull them out when we first started collecting the data. So the first data that went into analysis was H3, and they were pulling them out prior to the data going into analysis. So I think IQVIA was still sending all of that data over. Mm-hmm. And then they would pull it out prior to the data going into analysis. So here is the case count. I'm in the isolated cabbage. Under demographics, you'll have the case counts here. So I can see that for 2020, this is the H3 report. So this is period ending June 20th. I can see that we had over 63,000 isolated cabbages in the database total. Okay, I guess we're over a few minutes. Where can I'm going to take Diane's question because I think we might need to talk about where can I find the percent of patients extubated less than 6 hours within the reports on the IQVIA platform, unanalyzed and analyzed for isolated cabbage. And I think if we're not reporting it, I know we need to report it. But let's see here. I thought we were, or else it's on the list to get added in.
Let's see.
I think it's in. Yeah, it should be. I think it should be here.
Which section? Let's go through.
They're going to be here. This is the post-operative information section, or it's going to be in the mortality morbidity section. But if we're not reporting it, we should report it. We might have to add that back in.
Just need to verify where I remember seeing that there are many sections of this report.
Yeah, we just have prolonged event here. I want to see, is it in? So that's a good question, Diane. Thanks for bringing it up. And I think, let's see here. I think we had talked about it before and we were going to add it in. So it might be on a list for elaboration.
And I'll recheck and confirm with Diane. Mm-hmm.
Yeah. Okay. All right. I guess.
Carol, Karen said it's in the post-operative
section. Okay. Yeah, I just saw that too, Bonnie, also.
Okay. Hold on. How did I not see it? Oh, here it is. It's hidden, Diane. It's under initial vent hours percentage less than 6 hours. Thank you. Thank you, Karen, and thank you. Who else told me that?
Bonnie also said. Thanks, Bonnie.
Thank you. Okay, I think we're going to stop there and end it because I know I want to be respectful of everybody's time. If anybody has a question that we didn't get to, please reach out at ccrone@sts.org, or if it's for IQVIA, I'll get you to their email. Here, oh, where'd your email go? It's ststechsupport@iqvia.com or ccrone@sts.org. So thanks again, everybody, for joining, and I hope you have a great rest of the day. Thank you, Melanie. Thank you so much to, where'd she go? Patty drop off? Thanks, Patty. Thank you so much, Patty, and thank you, Melinda, and IQVIA team and STS, Emily Conrad, and Sydney Clinton, and Leanne and Catherine for joining. I hope you all have a great rest of the day, and we'll talk again soon. Thank you.
Bye, Carol.
Thanks,
Bye,
Carol.
guys. Thank you.
Bye, Carol.
Bye, Catherine.